and gentlemen, please join me in giving a round of applause to Doctors Chima and Dr. Amina as they come forward. These are interesting cases, so you won't just see them every day.
Good morning. Good morning, everyone. And welcome to today's session. I'm Dr. Chima Rupert. So today we'll be taking some case reviews. These are patients that we have managed in cardiac care hospital. So starting the first case. Okay, so the first patient, case 1, 56-year-old female. So she was actually referred from another facility here in Abuja. So she presented with palpitations and altered sensorium, non-hypertensive, non-diabetic for over 10 years, and her regular medication, she was on some antihypertensives, Exforge, bisoprolol, some anti-diabetic agents, Gavosmet, Amaryl, and statin, atorvastatin. So she was taking the medications regularly and has been compliant with therapy and also follow-up at the referring facility. Previous ECGs and echoes done by a primary cardiologist were said to be normal. She had no chest pains, there was no history of use of any caffeinated products or any pro-arrhythmic agents. And she was referred on account of severe arrhythmias for further evaluation and management by our team. So these are presenting ECG. So on the ECG, you could see she has some wide complex tachycardia there on the precordial leads. And so this was the presenting ECG. So at presentation to cardiac care, this was our ECG at presentation to cardiac care in the emergency room. So on presentation, we usually do our ECGs within 10 minutes. So on presentation, her blood pressure was stable, 124/68. Pulse rate was, she had a bit of tachycardia.
Can you go back to the ECG?
Okay.
The one before your own.
Yes.
And then your own.
So this was the referring one. Then this was our own done in the emergency room.
Is there a change?
Yes, there's a change. There's a change.
What is the change?
So, so obviously she had no, it's not the same rhythm. She had VTs, ventricular tachycardia. Then here was more of sinus rhythm. There were Q waves on the V2. But the ECG obviously changed from referral to presentation. Yeah, obviously not sinus rhythm. Ventricular tachycardia, sinus rhythm on presentation. So, like I mentioned, her vital signs, blood pressure, pulse rate, the regularity of the pulse, she had ectopics, and she was fully conscious, not in any respiratory distress, and other examination findings were essentially normal. So, due to the nature of the case, we admitted into the ICU and placed her on continuous cardiac monitoring, also placed her on antiarrhythmic agents, oral amiodarone, as well as anticoagulation. So she was actually stable, apparently stable until about 6 hours later. The blood pressure changed. You can notice the drop in blood pressure from presenting blood pressure of 124/68 dropped to 82/49. So then also dropped further to 78/40, and the heart rate went up to about 178. Pulse rate was present, and clinically she was quite diaphoretic. She was drowsy but responsive, but she was sweating excessively. And so the ECG done on the monitor was similar to this presenting ECG with the wide complex tachycardia. It was seen on the continuous ECG, the cardiac monitoring that was done, and we immediately started IV amiodarone. Loading dose was given and subsequently continued on continuous infusion. She didn't respond to the IV amiodarone therapy, and we had to DC cardiovert her with the defibrillator in the ICU before the reading changed. So we started her on IV amiodarone. She wasn't responsive, and we had to DC cardiovert her. So by day 4 on admission, she was relatively stable in the ICU. She was requiring high maintenance dose of amiodarone, and we had done a coronary angiography, which was actually normal because we had to evaluate why is she having these abnormal rhythms. So we did the coronary angiography, was normal, and we did the ICD. We inserted an ICD for her. Intra-op, during the course of the procedure, because they were done on the same day, she had multiple episodes of VTAC. I'll show the strip so we can see. So we can see the rhythm intra-op. She had about 4 to 8 episodes of VTAC during the course of the coronary angiography. You can see the rhythm there. So I hope you can appreciate the ventricular tachycardia, the wide complex, the QRS complexes. So this was what we saw during the procedure.
Go back.
Okay.
Go back. So go that slide down.
Okay. This. Okay.
So I think we can see the wide complex tachycardia, and we can see where it is written shock. Can we see shock? Where it's written shock, and see the rhythm after the shock. Okay, and this is why ICD is being placed. You see the X-ray of the lower right corner. Well, it's not X-ray, the fluoro. That's the ICD. It's under the skin, placed, and this is happening. So 2 cardiologists have to take over ACLS while one person continues the procedure to make sure that we are complete, and then the cardiac nurses and everybody continues other things. So the only person doing the procedure has to stop anytime there's a shock to be delivered. Everybody stop, shock, and then you go back and add your IV amiodarone. So we will talk about ACLS later today and highlight some of the things that should be done, and you will, when we talk about ACLS, you will see some things we did not in the correct order. By then you appreciate it, but either way, we still got a good outcome. Okay, so it's just something to note. So go back there.
Okay, so this is actually following implant. So after we implanted the ICD, patient was on continuous cardiac monitoring. So you can appreciate, this is the ECG from the cardiac monitor. Patient was having another episode. Okay, so let's come on again. Okay, you can see the wide complex tachycardia. Then we can see the ICD device shocking her and it's changing. So if you also note, during the course of when she was having the wide complex tachycardia, you can note the change in vital signs. You can see the heart rate going as high as 190. Then while after shocking, it drops back down. So that's the importance of an ICD in a patient like this. So you can see it's the wide complex tachycardia, then administer the shock and the change in the heart rate. So she's actually, she was actually discharged on oral amiodarone and she has done very well. So this is her last clinic visit, ECG on last clinic visit. So we can appreciate the ECG, she's having sinus rhythm. Patient is doing very well. I hope you can appreciate that. So case 2, Dr. Amina will be taking case 2.
Go back to the case 1. It was not as easy
yes,
as it was presented, because at the end of the second case we understand why we're presenting the 2 cases, that this is a patient pre-ICD. She was having frequent VTs.
Yes.
Then even after the ICD was inserted, she was still having, and when you are having that frequent ventricular tachycardia within that short period of time, that is what we call ventricular stop. This patient had loading dose of amiodarone, maintenance dose, still having shock. We had to use lidocaine before we were able to get this rhythm under reasonable control. And
I didn't see him say. I didn't hear him say you gave.
That's why I said it was not as easy as it was presented. That with amiodarone there was nothing different shock. Then when the ICD came, frequent shock within few hours until we started the lidocaine, and things started getting better, and she was eventually discharged home on amiodarone, and she's been doing very well. Amiodarone and other guideline directed medical therapy for heart failure, and she's been having a frequent visits.
What is the trigger, sir?
The trigger for her, not really sure, because the electrolytes were fine. The thyroid function test was good. The angio was normal. So we tried to look for electrolyte derangement, thyroid dysfunction, myocardial infarction. We couldn't actually get.
The only thing that I think will be there are Q waves in all those leads.
Yes.
And in our Nigerian patients, when they have an MI, if not that I saw the ECG of STEMI and the troponin from a reputable hospital, a lot of times when they come in 1 month, 3 months after, the coronaries may be completely normal. So having a normal coronary angiogram at this time does not mean that she did not have a previous MI and had a scan. The Q waves in the anterior leads may give a suggestion towards that. We've had several cases. If not that I know the consultant and I've seen the troponin and I saw the STEMI on the ECG, I will have sworn that nothing happened to that patient. So it's one of the possible things that I can put together here. But electrolytes, magnesium, calcium, all the other things, otherwise fine.
Both cases, their coronary angiography were clean. Even the second case that is also going to be presented.
Yes, sorry, just a comment. Could it be some form of vasospasm? Could this patient have benefited from some form of calcium channel?
Calcium channel blocker?
Yes.
It's possible, but sometimes we see the vasospasm when we do the coronary angio that we have to even give intracoronary nitroglycerin to relieve it. But the arteries were fine, although we were doing the coronary under, a lot of duress. So we did not take all the views because it was really, an ACLS really. So that's a possibility, sir. Please go ahead,
Chief.
Thank you, Dr. Chidi, for your presentation. I was wondering, is it possible, given that we're not able to find, any trigger, is it possible that an EP study could have been helpful?
Definitely, an EP study is, not in the acute phase. You still have to do this, and an EP study is very good. We've talked about it. We are trying to make arrangements for that. In fact, she came back 9 months later or 1 year later with another short set of shocks and had to be admitted, check the ICD. The ICD did some work and we had to adjust doses of drugs again. So yes, definitely, she's on both amiodarone and beta blocker at very good doses to be able to keep her well controlled. So definitely an EP study is.
So
but I still think that even the EP study will still be down to a previous infarct and a scar somewhere. That is now the trigger or the focus for all of these studies.
So EP study and possible ablation, radiofrequency ablation.
EP, for the people, EP means electrophysiology. And just the same way we do in the cath lab, it's like doing an ECG inside the heart. So we take the different wires or whatever, for lack of a better word, and we put it at different points on the conduction pathway. Then we try and trace how the origin of impulse is moving through the heart. We do that first. Then we'll now try and induce abnormal readings from different points to find where is the origin coming from and how is the electrical activity passing through the heart. When we now find the abnormal pathway, then we can now give some ablation. Either we use laser, we use cryo, and burn off the area that is causing that recurrent abnormal reading. So that's what EP stands for.
Yeah, just to add that maybe something else that could have also been helpful, for the patient could have been a cardiac MRI, because as you mentioned, fibrosis, infarction, and MRI would probably, give.
Definitely, the MRI that is typically helpful in this case should be 3 Tesla and above. 1.5 may be help, but 3 Tesla and above. To my knowledge, there is none available in the country, and the 3 Tesla MRI needs to have 24 hours power, 100% of the time for several years for the lifespan of the machine. So I hope you understand what that means. It means generators are constantly running, your helium is constantly running for it to maintain. That is why nobody is keeping a 3 Tesla in the country at the moment. So anything less than 3 may just be a futile something. And in the end, really, if you're not doing EP, it may just be academic. You just find it and just for publication purposes. Thank you very much. Can we give Dr. Chima a round of applause?
So, good morning, everybody. My name is Dr. Amina, and I'll be presenting the second case. Okay, so this is, he was a 52-year-old male who had heart failure with reduced ejection fraction. He had had it for about a year and a half. His EF at the time of presentation was only 28%. So this is his echo when he initially came to us. Okay. Okay. And this was also his first ECG.
For the sake of the audience to at least learn something. Yes, this is echo. What did he show? It was in a passing, Abi. So that people can gain. Am I right? Oh, you don't like it? What did the
Please,
echo
let's have the slide back.
summarize? What did the echo show? What okay.
So this was the echo when he came in, and like the doctor said, he had heart failure with reduced ejection fraction. Then the restrictive left ventricular diastolic dysfunction. That's the worst of the relaxation impairment that you can have in patients with heart failure. So he had that, and we can also see his strain image. Please, let's look at the previous slide. We can also see his strain imaging, that apart from just looking at the global contractility of the left ventricle, you can even see each segment of the left ventricle, their contribution, and you can see those areas that is it blue or green now? I don't know. I'm not good with color. So those areas are the contractility from those areas are very, very poor. So at this point, we were thinking he had heart failure from ischemic cardiomyopathy. So the plan was to schedule him for angio. He started guideline-directed medical therapy to look at him before things started happening to him.
Okay, so I know we are still compiling our data and we should actually publish. Hopefully we publish. But this kind of strain pattern from unpublished data and relative experience will not, now as with hindsight, does not correlate with coronary artery disease, it seems, because it's very diffuse. So it is no longer, I mean, there was a time when we thought, wow, especially when we first got strain in 2017, speckle tracking in 2017, we thought, okay, likely. But by the time we started doing coronary angios and trying to correlate, it's the ones that really correlate are when this pale, so audience, what we see that color, that thing that looks like a bull's eye, blue, pink, red in the center, and blue. It's supposed to be bright red like meat, like nama. It's supposed to be bright red. By the time it starts, the cardiac function is not working well. It starts getting pale red, pale, and when it's really even not even contracting and it's going the opposite direction, it turns to blue. So that is essentially what we are looking at. So the ones that seem, again, different studies have already tried to do it, but they have conclusively said there is no direct correlation between this and coronary angio. But from our small experience combining and looking, if you have it specifically in one area, then it almost always correlates with coronary artery disease. But it's just anecdotal. We have not published it. It's just trying to put 2 and 2 together in the cath lab, comparing it to our echo results. Okay, go ahead.
Okay, so he went on to have an ECG. So in ECG, he had wide QRS complexes, and he fit the criteria to have a CRTD inserted.
That's a VTAC.
Okay. Yes.
Okay, so what you are seeing on the ECG, actually, you are seeing PVCs. The rhythm is there under, and then those wide ones are separate from the normal rhythm. So when you see a PVC, can see the abnormal one, the one that looks like Jaga Abi. Hello, can we all see? Don't worry, we'll do ECG today. We have to use for the computer. Mr. Nokela, can somebody use the pointer there? If you see the ones that are polarized, maybe the pointer will not work on the screen. Dr. Oleko will show us. So these ones that are broad, that Dr. Oleko is pointing to, they are the Bizel ones. Typically, sometimes some patients can have 1 or 2 on their ECG. We'll say they are ectopics. By the time those PVCs happen 3 or more consecutively, Once you have 3 together, we'll now say this is a VTAC. If it runs consistently for 30 seconds or more, we say it is a sustained VTAC. And if it doesn't run up to 30 seconds, we say it's a non-sustained VTAC. So what we are seeing here is a non-sustained VTAC. Okay, and definitely this patient will need, number one, we wanted to investigate the cause, and number two, with the severe reduction in ejection fraction, the patient will need an ICD for the case.
So this is in the cath lab. So if you look at it, similar where it says trouble starts, you can see where the VTAC is happening, and then the device delivers a shock, and after that he returns to sinus rhythm.
Okay, so this is, I hope you can see the time there. That is 1:50 a.m. So we are half asleep at that time. And after coronary angio, it goes straight into that VTAC that was non-sustained, suddenly becomes sustained. Now, in this case, patient is with you on your emergency room, and you notice this. A lot of us have monitors in our hospitals, but we are not using them. So now you can see this rhythm changes. But beyond it changing, you are not going to wait for 30 seconds to say, no, it's sustained. Dr. Iseko said he should wait for 30 seconds. No, not like that. So immediately he lost consciousness, and, you know, I had dozed off a little bit. And then Dr. Daffer was there, and everybody shouted. So within 10 seconds, we shocked him, and then you can see the sinus rhythm coming back.
Okay. So this is after he had the ICD in place. His heart failure treatment was optimized. He was on guideline-directed medical therapy, and he seemed to be doing well. He was discharged home. So, and he came for regular follow-ups. So after a year, after he had had the ICD inserted, he presented recently with complaints of chest pain that had started about 4 hours prior to presentation. It had happened in the middle of the night, woken him up suddenly from sleep. He described it as sharp, generalized, and did not radiate. He also had associated episodes of sweating during the episodes of the chest pain with episodes of syncope. And the episodes lasted about 30 seconds before spontaneously going away. So he came back to the hospital very early in the morning, and at presentation he was noted to have an elevated blood pressure of about 159 by 100. He was tachycardic with a pulse rate of 112. His heart sounds were S1 and S2, and the other aspects of the cardiovascular examination were normal. So he was placed on continuous cardiac monitor while in the emergency room, and that continued to show episodes of intermittent ventricular tachycardia. Okay. So he had a 12-lead ECG done immediately, and this was the ECG.
Go ahead, explain it. Go ahead. Try it. It's complex, yes, but try.
So he is still having the episodes of the VTAC, okay? However, because he also has an ICD, the rhythm looks very, very abnormal. Very wide.
So what do you think is happening?
Was it capturing?
Sorry?
Was it capturing? Was the ICD doing his work?
Yes, the ICD is doing its work.
Did you see it on the ECG?
No.
So what you can see here, there are several possibilities. So I'll just explain this briefly. The first possibility is that he's starting to have a VTAC. Can you see how wide the QRS complexes are at the beginning there? Maybe I should go up. Okay, I think you can see how wide the QRS complexes are at the beginning here. From here to here is wide. For those that are wondering whether that is wide, this is not wide. We can see this is not wide. But from here to here is wide. So the first possibility is that he's developing a VTAC. And then the machine, the device in his heart treats it, and then it comes back to normal. But no sooner that it treats it, it takes up another set of VTAC. Possibility number one, which you can only know until you interrogate the device. This is from the surface ECG. Possibility number two, a VTAC was about to happen, but before it went that high, the machine starts pacing. So the device in his heart can also act like a pacemaker. And typically when a pacemaker is pacing, it gives this wide, complex kind of ECG. And so the pacemaker starts, and what it does is to pace higher than the rate that is already coming up. So let's assume the heart rate is about to go up, it gets to 110, gets to 120, gets to 130. The device will take over and start pacing at 150. Shebi you want mad, we'll give you higher madness. And take that higher madness first, then now bring it down slowly. So the device starts pacing, tries to bring it down. When it tries to bring it down, the thing wants to start again. The device takes over the pacing again. So those are the two possibilities we can see on the surface ECG. When you now come to the interrogation and put your magnet over it and look at it on the system, you can tell which was which, because the device is inside the heart and is giving us real-time information about this. This is advanced cardiology, I'm sure.
Okay, so he had some investigations done. He had an urgent troponin. We checked his electrolytes, UCR, and also did other electrolytes like magnesium, phosphate, as well as a full blood count. Okay, he was admitted into ICU immediately. He was started on antiarrhythmic IV amiodarone, as well as a high dose of beta blocker metoprolol succinate. And then he continued to have intermittent episodes of the VTAC, and so he had to be started on IV lidocaine. The device was also interrogated. So the serum troponin, when it was done, it was found to be elevated. He also had a coronary angiography done, which was also normal.
Why was the troponin elevated and the angio is normal? Why do we have a high troponin with a normal angio? I'm drilling you the way we will drill you in our rooms, right?
That's higher cardiology. They can try, but I think it's slightly a higher cardiology.
Okay, so sometimes when you're having VTAC and that level of activity happening, troponin can go up. Okay, so troponin can go up with that, with the number of shocks also from the device. It is also, it's inside the myocardium. It also can cause the troponin to go up. So it can give a false number. But in this case, we must do the angio because he had chest pain, troponin is elevated, and he's having sustained VTAC, which tells us that is it possible that he's having an MI that triggered his, after all, he was stable for 1 year. So that is why we still have to do the angio. I hope this is beneficial to all of us. Or it's too high. Everybody's quiet. That quiet is that you understand or you don't understand. Go ahead.
Okay, so that's essentially it. He actually did well, was later discharged, and he's being seen on outpatient basis for follow-up. Okay. So what we've basically talked about are ventricular storms. These are uncommon but life-threatening complications where a person has multiple episodes, usually 3 or more, of ventricular tachycardia within 24 hours requiring intervention. And the reason that they're so important is because they do pose a risk of sudden cardiac death, even in people with implantable devices. And the prognosis of those who survive is actually, it can negatively impact the prognosis of those who go on to survive. So the initial step in management is obviously we need to resuscitate, we need to stabilize the person. So we do so by the ACLS protocol. Sometimes it can lead to hemodynamic instability, and they may also have comorbidities. So they're usually admitted into ICU, as you can see was the case with all of these patients that we presented today, because sometimes they may even require intubation, some require hemodynamic support as well. So the main thing that you want to do is you want to find out the cause, because if it's a reversible cause, you can just reverse it and the patient should do well. So sometimes it can be electrolyte imbalances, things like hypokalemia. So if you notice, we did check our electrolytes of all of our patients. We also went to do things like magnesium, phosphate as well. Okay, so it could also be an acute ischemia. So some of them could have been having an MI, worsening heart failure, things like sepsis, or maybe they're not taking their medication, or they could have been started on another drug that is pro-arrhythmic as well. Okay, there can also be some non-reversible causes, so things like scars that we spoke about just now. Sometimes chronic renal failure, like things like a ventricular aneurysm, and even things like tumors within the heart can become a substrate for these arrhythmias. So following stabilization, you want to take a focused, detailed history, mainly to try and find out any precipitants, any causes things like that, okay? Then you want to examine the patient, you want to find out for any signs of heart failure, signs of cardiogenic shock, and then you want to also know everything that you can about the device. The device of most of these patients was interrogated as well. Okay, so key investigations, obviously, like we said, we want to do our electrolytes, things like a BNP and troponin levels to find out the underlying cause. Whenever it's possible, you need to do a 12-lead ECG, and it will help to basically find out exactly what's happening and the mechanism of the VT. Okay. Then antiarrhythmic regimen, including beta blockers and imidazole, like was done in our patient, as well as lidocaine for the second patient as well. Okay. And what it will do is basically suppress the arrhythmias. If there is an indication of an ischemic trigger based on the history, the ECG or the echo, then a PCI may be warranted, maybe together with the coronary angiography. And sometimes, like we saw, when they have sustained VTAC with hemodynamic instability, they may need DC cardioversion, as was the case in the first presentation. Okay. So this is just a summary of our SOP, our standards of practice on electrical storm. So the definition, like we've spoken about before, you want to find out the etiology. Like we said, the prognosis, it typically has a bad outcome, so it is important that you admit the person into ICU, and multidisciplinary management is going to be required. So for the investigations, like we said, you're going to do an ECG, an echo, the troponins, your electrolytes, thyroid function test as well, and then the device needs to be interrogated. Once again, for the management, so arrhythmics, so IV amiodarone, lidocaine, they also need beta blockers as well. Then other treatments, so like we said, the PCI may be required, treat the precipitant, and if they don't have an ICD, they need to have one done between 24 to 48 hours. Then hemodynamic support as well if they need it, plus minus intubation. And obviously counseling the patient on what has happened, just letting them know that you are there to support them so that they are happy to come back in case anything changes. Okay, I'll continue. Okay.
All right, that's fine. Can we give her a round of applause? Please, let's do better.